unit per liter, and for ALT, the upper reference limit for males is 60 unit per liter, and for females is 42 units per liter. Now, the reference range, we'll come back to this reference range question later when I will be discussing about the elevated transaminases in asymptomatic patients. So we'll come back to this, but for now, this is the reference ranges which are defined. Transaminases, basically, if we talk about the clinical significance, they are used as indicators of liver cell injury, and they are very sensitive indicators for that matter. And any type of injury to liver cells can lead to mild or moderate increase in the transaminase levels. However, striking elevations of aminotransferases or transaminases occur in exclusive disorders which are associated with extensive hepatocellular injury. Now, when I say extensive hepatocellular injury, the three common conditions that are known are viral hepatitis, ischemic liver injury, and drug-induced liver injury. Now, one thing which needs to be considered here is the enzymes we are talking about. When we talk about the reference range in healthy individuals also, it is the basal level of these enzymes which is present in the serum. Okay. Now, all the diagnostic enzymes that we use in clinical setting, their concentration in serum which we are detecting, it depends on many factors in general. One is their tissue distribution, where the enzymes are distributed. Then subcellular distribution also, like in the cell, whether they are in the membrane, cytoplasm, or in the mitochondria. And then it depends on the concentration, the difference in concentration of the enzymes in the plasma and the tissues, and also the pattern of release and clearance from the serum. So all these factors in a general way contribute to the levels of the enzymes in the serum. So likewise, in case of hepatocellular injury, when the hepatic cells are injured, so these enzymes which are concentrated in the hepatocytes, AST/ALT, they are released into the serum, and we can see a striking elevation in the level of aminotransferases in these cases. So likewise, we can say that in case of any cell injury, in case of any liver cell injury, we will see a elevation of transaminase. Now, I have some food for thought for all. So now, while making the presentation, I was thoughtful that if both ALT and AST enzymes are giving us the same information, then why in most of the LFT panel which are done by the clinicians, both these enzymes are included? In all the panels, anywhere you will see, we see both ALT as well as AST being tested. So are we doing over testing here, or is it that only one of the enzymes, if we do ALT, which is considered to be more liver specific, will it suffice? So that is something we need to ponder about, that how do we need to proceed? And if we believe that yes, both the enzymes are important, then what is the additional information they are giving us? So the additional information, yes, of course, is given, and here comes the role of deritis ratio, where we will in my presentation further I will cover how it provides additional information on the prognosis and diagnosis in liver diseases. So that's why we are talking about this ratio here. And one more thing which I think most of you must have encountered, that in many clinical settings, we encounter certain reports where we are reporting LFTs, and we see that transaminases are elevated, maybe mildly, but the individual is asymptomatic, or there are no signs of liver disease even on subsequent workup in those patients. So what can be the reasons for that? So we'll just cover these points one by one. So if we talk about comparing ALT and AST and enzymes and selecting one of them, then which should be more specific? Now, if it's very well known that ALT is more liver specific. When we
Shiba,
say more liver
Dr.
specific,
Shiba, I'm sorry.
Now, is it visible now?
Yeah.
Okay, so basically, I was talking about the transaminase levels which may be elevated in asymptomatic patients and individuals. So the main reasons, which can be enumerated or attributed to these is the intra-individual variations that may occur Like it is seen that in 30% of individuals, these transaminase levels on repeat testing give normal values, and it is also based on the difference in values in men and women, like the variations based on the gender. Sometimes we use the same reference range for both male and female. However, there is some level of variation for these transaminases. Then there is an variation seen with respect to BMI, and this is associated with obesity, because in obese individuals it is seen that ALT is elevated. So that can also lead to elevated transaminase in these individuals. And also in strenuous exercise, it is seen that AST, both the AST and ALT can be elevated. However, the elevation in AST is more than ALT in these individuals. Now here, when we talk about strenuous exercise, there's a condition rhabdomyolysis. In that also both AST and ALT increases, but the increase in AST is more, obviously. But why I want to just bring it here is that the AST would be cleared faster from the serum in such patients than ALT. And the ALT, if it is like in the chronic rhabdomyolysis, like rhabdomyolysis has occurred, and in a chronic condition, if we measure this ALT, it can lead, it can be reported as a higher value. However, it is not due to any hepatitis, it is due to the persistent values of ALT in the serum. So these can be the reasons for elevated transaminases. Now we have also seen in various settings where isolated elevation of AST is present. So does an isolated elevation of AST always suggest a non-hepatic source? Yes, mostly it does. That it can be due to injury to non-liver cells, but there can be other causes also, such as sample hemolysis. Now in cases of hemolysis, the AST which is present in RBCs, that can also lead to an falsely high levels of AST. However, in these scenarios, mostly ALT is normal, and also it can occur due to reduced clearance of AST from the serum. So they can be causes for this elevation of AST. Basically, isolated elevation, when I say, it is only AST rising and ALT is normal. Now, these are various clinical case scenarios. I'll just cover them very quickly. Like suppose this is a person, an army person is found drunk during his night duty and is immediately arrested and admitted in psychiatric ward. Now in this person, when serum GGT is done, it is normal and AST-ALT ratio is greater than 2. Now this is a real scenario which was discussed with me by senior. So now sometimes what I want to depict is, sometimes now GGT is also increased in cases of alcoholic hepatitis, and we already it is discussed that AST-ALT ratio is also greater than 2 in alcoholic hepatitis. But when we are facing real scenarios, sometimes the absolute things which we read may not occur, and it may be in like it may we may have to correlate it in a different way. So now in this scenario, what will we interpret? Was the person drunk actually and was having alcoholic hepatitis or no? So here, if we are doubtful, obviously one thing is that we'll go for repetition of tests, one thing, and we may test for other markers also. Like nowadays, we do this carbohydrate deficient transferrin for to confirm if the patient has taken alcohol in previous 14 days or so. But yes, these markers, when if you go through this, GGT is associated with alcoholic hepatitis, but it may be associated with alcoholic hepatitis. It is not mandatory that it will be raised. So we can find such scenarios in our day-to-day practice. So and then it becomes really interesting to think about them and correlate them. Now another scenario here is a clinical chemistry lab receiving a particular patient sample daily from ICU as part of monitoring normal LFT for 3 days post-op. So for regularly for 3 days, the LFTs are coming normal, and then suddenly 4-day AST is found to be around 1500 unit per liter, and ALT is 250 unit per liter, while bilirubin level is normal. So what can be the possible interpretation for this? So when it was like the history, because for the interpretation, obviously the history was taken, it was found that previous night the patient had cardiac arrest and CPR was done. So now what do you think can be the possible cause for this? So some would say that yes, it is the cardiac cause for the AST, and basically here in this particular case it was a sporadic rise, because again the fifth day it was all normal. So here the cause, if we say that the cause was cardiac for this AST rise, then it does not justify this ALT, which is also raised. So now in this particular patient, the explanation is acute ischemic liver injury. So what happens is that in cardiac arrest, what happens, there can be ischemic injury to any organ, including liver, although liver does not easily have this ischemic injury because it has a dual blood supply, and that's why it is like rarely goes into ischemic injury. But yes, in this particular scenario, the patient suffered from acute ischemic injury, which explains for the AST as well as rise in ALT. However, these levels come to normal level within within a day or few hours. Like there is a quick dip in these levels. Then there is another scenario wherein there is a 55-year-old female presented as a referral to her gastroenterologist, and basically why? Because the laboratory analysis revealed elevated AST levels for the last several years without any associated elevations in ALT, alkaline phosphatase, or bilirubin. Now, when an extensive workup of this patient was done, it was found out that this raised AST was attributed to macro AST. So we should also look up for this macro enzyme. Now, what is macro AST? Basically, the enzyme that is AST, it combines with the FAB fragment of immunoglobulin, and now this complex, it does not get cleared from the serum for long. So it persists in the serum and it contributes to the elevated AST levels. So now there is no as such clinical significance for these macro enzymes. However, these can lead to unnecessary diagnostic workup. So their possibility should also be kept in mind when we are dealing with such scenarios in the lab setting. So now the concluding thoughts on this talk is that should the testing of AST be done in addition to ALT, or should it be limited? So one thought which is also said is that ideally in the LFTs we should just include the test for ALT. We should just do ALT, and if the ALT values is showing a twice increase in the upper reference limit, then the laboratory should do a reflex AST testing and give a ratio of AST-LT in the report. So should it be the practice should vary, or should it continue as both the ALT and AST enzymes being done together? Then the second thought that comes is, should dendritis ratio be included in all clinical reports for LFT? Now, if this ratio is important for the prognostic and even predicting the fibrosis and cirrhosis, as we've just discussed, we have clinical decision limits for that. So should it be included in the reports for LFT? However, this particular thought is limited by the fact that we need to have this ratio levels, the reference ranges for this ratio in healthy individuals. We do have various studies reporting the ratio in healthy individuals, but yes, more work needs to be done in this aspect. And the third thing is, is there a need for harmonizing all the methods for AST-LT estimation with respect to the use of PLP? Now, most of the tests do use PLP in the reagent kits, but some also some are there like which do not use. So likewise, we should have an harmonizing of all the methods on the same platform, I mean following the same principle with respect to the use of PLP. So lastly, I would like to acknowledge my department for their constant support and encouragement, very especially my HOD, Dr. Dinesh Puri sir. And then I would like to acknowledge the ACC LMP team, very especially Dr. Sushruth Sen sir, for giving me this opportunity to present this talk, and to the Rajasthan chapter, I congratulate them for organizing this webinar and considering me for this talk. And last but not the least, Dr. Arun Harith sir, for giving me this idea for making this presentation in this manner and giving his inputs, and also helping me decide the title. Thank you so much.
Thanks a lot, Dr. Shiba. That was really a wonderful and insightful as well as lucrative presentation by you. I will now quickly introduce the next speaker for this session. She's
So, continuing with the talk. So, if we are to select one specific test out of these, so ALT is always considered more liver specific, and why? Because if we talk about the tissue distribution of enzymes, AST is also present in cardiac muscles, then in skeletal muscle, and also in kidneys. But if we see ALT, it is also present in other tissues also. However, ALT is considered more liver specific, and the other reason which is given is that increase in activity in the serum persists for longer than AST. And why it is so is because the plasma half-life of AST is 18 hours, whereas that of ALT is 36 hours. What does it mean? Now, whatever these enzymes, basically they are protein and they are there in the serum, but there is a constant clearance of these enzymes from the serum. So what happens is, I think someone is, please everyone mute yourself. This is a request. So now the clearance of AST is faster from the serum, so that leads to a reduced half-life of AST when we are comparing with ALT. It is almost half. Or you can say the clearance of AST is twice more than that of ALT from the serum. So the ALT activity persists for a longer time. Then ALT, if we see in the initial phases, like mostly if we see that ALT is uh, the ALT is present in hepatocyte cytoplasm, while AST it is present both in cytoplasm and mitochondria. And in fact, the AST in mitochondria is known as MAST, and in cytoplasm is CAST, and they basically correspond to two different isoenzyme forms which are genetically different. So now if we talk about the tissue distribution, so whenever there is hepatocyte injury or any cytoplasmic leak from the hepatocytes, mainly ALT and cytoplasmic AST are seen primarily. However, when there's extensive damage to the hepatocytes, or you can say the mitochondrial damage is also there, in those cases the mitochondrial AST is also seen in the serum. So that way we have both ALT and AST being present in case of hepatocyte injury. So that's why I initially termed them as brothers. So they are basically side by side together. And the cytoplasmic enzymes, one thing which is to note, it's not that the hepatocytes have to rupture and release their components. I mean, it's not necessary that the cell membrane has to be injured and to release the enzymes. Even if there is an alteration in cell membrane permeability, then also these cytoplasmic enzymes from the hepatocytes may be released into the serum. So now if we talk about ALT versus AST, yes, we can use ALT as a liver specific enzyme, and its activity persists for longer, but AST has its own clinical significance when it comes to interpretation of various clinical conditions and in differential diagnosis of liver disease. So that's why they both are hand in hand, and we have to consider both in testing for when we are testing for the LFTs. Now coming on to the detritus ratio. Now this is an AST by ALT ratio, and I think everyone is well aware of this ratio, and because it's a useful indicator in predicting the etiology of hepatitis or the liver disease. However, this ratio varies with the dynamics of serum transaminase release and clearance from the serum. So basically, in the situations where AST and ALT is raised, we can interpret the etiology of hepatitis or liver disease by seeing this ratio. But in different conditions, why this ratio would vary is because of the dynamics of the release and clearance, which may be different for both the enzymes. So, likewise, I think this is broadly known that AST-ALT ratio of less than 1 is suggestive of acute viral hepatitis and also chronic viral hepatitis. and that of greater than 2 is suggestive of alcoholic hepatitis. Now, this we'll be discussing in a bit detail, because sometimes this absolute ratios do not work, and we may have a differential condition in even in setting of viral hepatitis and even in alcoholic hepatitis. This ratio may not be followed. So now if we talk about the ratio in acute viral hepatitis, the AST-ALT ratio is typically seen to be less than 1 and usually in the range of 0.5 to 0.7 in case of acute viral hepatitis. And when we are measuring this ratio, when we are testing for these enzymes and estimating the ratio, the condition is usually resolving when this testing occurs. And the ratio is less than 1 because in this setting, usually it is the ALT which is marginally raised. So the ALT activity is marginally raised, which basically makes this ratio to be less than 1. So and the condition is usually resolving. However, we may see conditions wherein in the setting of acute viral hepatitis, we may see AST-ALT ratio greater than 1 and even more than 2 also. Now, in that is suggestive of fulminant acute hepatitis, wherein there is enormous amount of tissue damage or the cell damage, and a huge proportion of these enzymes are released into the serum. So that is this ratio can give us an idea about the prognosis also, because if it is 2 and it is suggesting fulminant hepatitis, then it is suggestive of a poor prognosis. Now, however, we are not totally dependent on this ratio to diagnose a case of acute viral hepatitis, obviously, because nowadays we have serological tests and we are doing the diagnosis in correlation to them. But yes, these ratios can, even when we are monitoring such patients of acute hepatitis, these ratios can help us, predict the course of the disease based on these ratios. Like if this ratio is around 1.5, then we can predict a higher increase in ALT in the next few, like 24 to 48 hours. So this deritis ratio reflects the time course of acute viral hepatitis and provides a vital clue to the patient's prognosis. Now, in the setting of chronic viral hepatitis, like mostly what we encounter in this is hepatitis B and C. So this AST-ALT ratio is again, we see it is below 1, and the reason is same. ALT is much more raised in these conditions, but the AST-ALT ratio slightly above 1 may also be found, and in that scenario, it is predictive of progression to fibrosis and cirrhosis. And when we say, so basically in the setting of chronic hepatitis, and if we find the AST-ALT ratio to be above 1, then we can predict that the patient is progressing to fibrosis and cirrhosis. And it is to be noted here that it is the elevation of AST rather than ALT which is predictive of fibrosis. And the reason for this can be attributed, I mean, it is not totally certain, but yes, it can be attributed to the release of the release pattern of AST, which may be the mitochondrial AST, which is contributing more and contributing to an increase in ratio, or it can also be related to the reduced clearance of AST in this setting, or maybe both the enzymes, because the clearance for AST and ALT, both of them is done by liver sinusoids only, and in the setting of fibrosis, this can be affected. So likewise, if we see AST-ALT ratio above 1, it is suggestive of fibrosis and cirrhosis. Now, in case of alcoholic hepatitis, the AST-ALT ratio is greater than 1.5 to 2. And what is the reason, or what are the possible explanations for this? Is one, that mitochondrial damage leads to release of mitochondrial AST in serum. And when we talk about mitochondrial AST1, the AST amount is high. That is one of the reasons. And usually when these patients are tested, it is like within 24 hours of alcohol exposure, which is not the enough time for the total AST to get cleared from the serum. So we have more of AST. Also, I just came across some papers which also report that the T-half, the total half-life of mitochondrial AST is around 80 hours, which is even more than the ALT. So that attributes to this ratio being greater than 2 in the setting of alcoholic hepatitis. Another reason which is given is the decreased ALT activity may be due to B6 depletion. However, when we give this reason, you can easily question it, because B6 depletion would also affect the AST activity, because B6, vitamin B6, it is acting as a coenzyme for both these enzymes, right? So, but yes, this is also given as a reason for the ratio to be more than 2. Now, but this may not be an absolute when we are seeing patients in the clinical setting or in the practice, that it is not a mandate that these patients would have a higher AST-LT ratio. Why? Because there can be few exceptions wherein if we may encounter scenarios where this ratio is below 2 or even below 1. So one possibility can be, which is a more common possibility, that the alcohol exposure has been many hours, like the patient has reported for the test after many hours of alcohol exposure or maybe days, due to and in that time the clearance of the AST has also taken place, or it may also be suggestive of coexisting alcoholic as well as viral liver disease. So that can also be an explanation for these ratios. However, as I just told you, all these scenarios, we are not considering this ratio in isolation for diagnosing these conditions. So they are basically supplemental. Now, if we talk about NAFLD, that is AST-LT ratio in non-alcoholic fatty liver disease. Now, this is a very upcoming disease, and basically this non-alcoholic fatty liver disease is one of the most common conditions wherein we see now that the transaminases are raised in patients, and it is in association with the metabolic disorder. So now, before just going ahead, the NAFLD basically progresses in this form as initially a simple liver steatosis, that is the fatty liver, followed by steatohepatitis, wherein a slight inflammation sets in, and this further progresses to fibrosis and cirrhosis. So if we see the AST-LT ratio, it is less than 1 in non-alcoholic steatohepatitis. Again, because the ALT is found in this setting, the ALT is markedly raised. And if we see that this ratio in these NAFLD patients greater than 1, then it is suggestive of progression to cirrhosis. So we can say that AST-LT ratio, when it is greater than 1, it does suggest some sort of progression, or it can predict progression to fibrosis and cirrhosis. So that is in this scenario. Now we also see, now coming to the next thought that was provoked, was that elevated transaminase can be seen in asymptomatic patients. So now there are many scenarios wherein everything is normal and we see that transaminases, maybe they are mildly raised. So what can be the reasons? So one very important aspect of behavior is this intra-individual variations. Now, what do we mean by intra-individual variations? That in the same individual, when we are testing that enzyme at a particular time point, it is giving a certain value. And when we are testing the same enzyme after, say, a period of time, it is giving a different value. I mean, there is an intra-individual variation. So it has been seen that about 30% of patients who give a mildly raised transaminase value, basically the asymptomatic patients I'm talking about here, so they, on a repeat testing, they tend to give a normal value. Also, there is some diurnal variations also observed in the setting of transaminase value, especially ALT, and it is said that in the afternoon the value is more than that in the morning. However, the reason is still not defined. So there can be these variations which can lead to these values. Then we have seen that there is, you can say, a variation with respect to sex, that is men have higher levels than women. So this can also be a reason, but in the lab, mostly when we are reporting, we are using a single value. Sometimes we don't have a delineation that for men we will use a different cutoff and for the women we use a different cutoff. Sometimes we're using the same cutoff. So that can also be a reason.
Dr. Shuchi Goyal. She has been serving as a senior professor and head of the Department of Biochemistry in RNT Medical College, Udaipur, which is one of the prestigious colleges in our state. She has done her MBBS from RNT Medical College itself and has done her MD Biochemistry from JLN Medical College, Ajmer. And she's also a FAMER Fellow. And apart from that, she is the Nodal Officer of the MDRU unit of RNT Medical College, Udaipur. And her research interests include molecular genetics, newborn screening for IMD, and hemoglobinopathies. Over to you, ma'am, for the presentation.
Thank you so much. Am I audible?
Yes, ma'am.
Okay, thank you so much. Thank you so much, Garima. Good evening, everyone. Sorry for the delay. It was my first presentation, but because I was not able to join, I would quickly start my presentation, not wasting any further time. I am sharing my screen. Is my screen now visible?
No, ma'am, it is not visible.
Just give me a second. I don't know what's going wrong. Host disabled participant screen sharing. I think that's the reason.
No, ma'am, but you've been made the host by the ACCLNP.
Okay.
You can again try, ma'am.
It's again coming host disabled participant screen sharing. I'm going to share screen. Host disabled participant screen sharing. It is again coming there.
Just a moment, ma'am.
Okay. Is it visible now?
Ma'am.
Is it visible?
This is visible now.
Yes.
Yes, ma'am.
Yeah, okay, yes.
Yes.
Okay. So my topic was many facets of jaundice. So let's start with what is jaundice. Clinically, what is jaundice is a symptom with yellowish discoloration of the skin and the mucous. But if we talk back, hyperbilirubinemia. So as we can see, the eyes are deep yellow in color. So this is typically called jaundice or pilia in normal terminology. Before jumping to what is jaundice, let me give a how bilirubin is produced, because it's biochemically hyperbilirubinemia condition. So 75% of the bilirubin is basically derived from hemoglobin. So, and the senescent RBCs are broken down into RES cells of the spleen and liver. So bilirubin is basically derived from breakdown of heme, which contains porphyrins, but heme is also present in certain other compounds like myoglobin, catalase, cytochromes, etc. So what happens is heme is removed from the globins. As you can see, this is the porphyrin ring. Heme is removed from it, and heme oxygenase enzyme, it converts a linear porphyrin ring into biliverdin.
Make this in full slide.
Is it visible now to everyone?
Yeah, it's visible. Make it full slide.
Yeah, it's screen only. Full screen only.
First screen only.
First slide is visible, ma'am.
Only first slide is visible.
Yes, jaundice and
Acha, just a second.
yeah, now visible.
Yeah, ma'am, now it is visible. You can start with that.
Is it visible now, slides?
Yes, yes, ma'am. Yes.
Am I audible?
Yes. Of course.
Yes, ma'am.
Am I audible or not?
Yes, ma'am, you are
Yes,
audible.
ma'am.
You can
You
start
are
with the presentation. And the slide is also visible in the slideshow.
Recording in progress.
Am I? My slides are visible now?
Yes, ma'am.
Okay. So, jaundice is a clinically symptom with yellowish discoloration of skin
Madam,
and
your
mucous
voice is
membrane.
echoing, madam. Echo is coming.
Now is it okay?
Yes,
Is
ma'am.
it okay now?
Ma'am,
Yes, better now.
it's okay now, ma'am.
Okay. So clinically, jaundice is a symptom with yellowish discoloration of skin and mucous membrane. So biochemically, there is hyperbilirubinemia, that is jaundice. As you can see, there is yellowish discoloration of the eye, and this is normally called pilia as in common terminology. So what happens in jaundice is there is breakdown of RBCs, and these RBCs are usually broken down in spleen, reticular endothelial cells, and some in liver, but most of the bilirubin is derived from hemoglobin, that is heme. Globin is removed and the heme is remaining, which contains a porphyrin ring. Other heme-containing proteins like myoglobin, catalase, cytochrome also contribute, but the major fraction is obtained from hemoglobin. So what happens is this is the structure of porphyrin ring, and the methynyl bridge between ring 1 and ring 2 is broken, releasing iron. And this is converted into a linear molecule with the help of the enzyme heme oxygenase, and is converted into green color compound, which is known as biliverdin. This biliverdin is reduced and we get bilirubin. Now, bilirubin being an excretory product is also used as antioxidants. So basically this happens in spleen, and when this bilirubin is released from reticuloendothelial cells into the circulation, this type of bilirubin is commonly called as unconjugated bilirubin. Since it is not water soluble, it has to require a carrier, and that carrier is usually albumin. This albumin has two binding sites. One is high affinity binding site and a low affinity binding site. The bilirubin commonly binds with high affinity site first, and then when that site is saturated, excess bilirubin will bind to low affinity site. This low affinity site and high affinity site plays a very, very important role in Kernicterus or encephalopathy, which is seen a post increase in unconjugated bilirubin. At normal plasma albumin concentration, 20 to 25 milligram of bilirubin can be bound to high affinity sites of albumin and per 100 ml of plasma. This water insoluble bilirubin, which is released from RES, is known as unconjugated bilirubin. Now, this unconjugated bilirubin has to reach the liver, and this with the help of albumin having two binding sites. But then when it reaches the liver, the basic function of the liver is having three steps. First is uptake of the bilirubin with the help of a ligand in protein. Bilirubin binds with the ligand in protein, and this is again an energy-driven process. Both these two molecules, they combine and then they enter the liver cells as bilirubin ligandin complex. This then bilirubin, next step in the liver is conjugating the bilirubin. So first is uptake, followed by conjugation of bilirubin with glucuronic acid. This glucuronic acid is obtained, as we all know, is obtained from the uronic acid pathway. And this UDP glucuronic acid combines with bilirubin to form a monoglucuronide. And this two monoglucuronides will form bilirubin diglucuronide. And the third step in the liver is excretion into the bile canalicules. And this is again an energy-driven process. So there are two steps which require energy. One is at the level of uptake, and third is at the level of excretion into the biliary canalicules. So as you can see the structure of hepatocytes, there is a central vein here, and there is a canaliculus. These play a very, very important role in all the presentations of jaundice. So this is conjugated, and the enzyme for this is bilirubin UDP glucuronyl transferase, and this forms bilirubin diglucuronide. Now, this type of bilirubin, which has been combined with glucuronic acid, is now known as conjugated bilirubin and is excreted into the intestine through the bile. So excretion of conjugated bilirubin by hepatic cells into the biliary canaliculi again takes place by active transport mechanism. This bile enters into the second part of the duodenum at the level of ampulla of Vater. When this enters the intestine, the bile, as we all know, has bile acids, bile pigment, that is your bilirubin, conjugated bilirubin, then cholesterol, and mostly water. So bile acids are basically required for emulsification of fat, but bilirubin, as it reaches the large intestine, it is deconjugated again. The glucuronic acid is removed, and it is reduced to urobilinogen by the enzymes of the intestinal bacteria. Now, when we are talking about the intestinal bacteria, this is a very important thing, that in newborns, the fecal matter is known as meconium. The reason for this is the intestine of the newborn children is sterile. So they actually do not have urobilinogen in it. So this urobilinogen is actually responsible for providing color to the faces. So we started from the breakdown of RBCs in the spleen. They're destroyed in the spleen. This unconjugated bilirubin complexed with albumin is taken up by the liver. So there is an uptake process, there is a conjugation process, and there is an excretion process. Now, this bile is entering the second part of the duodenum, and from the duodenum, it reaches the large intestine. Here, the conjugated bilirubin is acted upon by bacteria, bacterial enzymes, and it is converted into stercobilinogen. This stercobilinogen has got three fates. The majority is entering the feces to, this is the major pathway. It provides color to the feces. Some of it is again returned back to the liver, and this is known as enterohepatic circulation, again to be released into the gut. And the third or very small portion of urobilinogen enters the systemic circulation and is giving color to the urine, because it is water soluble. Now, at any stage, you will see that conjugated bilirubin never ever in normal people does not enter the blood circulation or the systemic circulation. That is why the level of conjugated bilirubin is very, very less. Now, in what will be the medical application of this? Many a times unconjugated bilirubin is increased. So how do we excrete out that unconjugated bilirubin? It can be made water soluble by conversion into configurational isomers. These are known as photobilirubins, and these are formed when bilirubin is exposed to blue light at the 400 to 500 nanometer wavelength, and is a common form of modality used in phototherapy. These photobilirubins cannot form the intramolecular hydrogen bonds, which is very characteristic of bilirubin, natural isomer of bilirubin. So they are more polar and readily excreted in bile without the requirement of glucuronidation. So these photobilirubins are known as lumibilirubin, and ZE and ZZ, a structural isomer of bilirubin, is formed by intramolecular cyclization, which is stable, polar, and is excreted without conjugation. So this is the, these observations, they actually explain the mechanism of phototherapy, which is commonly used as treatment in neonatal hyperbilirubinemia. Then we come, now we have understood the basic bilirubin metabolism. We come to jaundice. As we all know, jaundice is yellowish discoloration of skin and mucous membrane, and the patient usually come to the doctor and say कि मुझे पीलिया हो गया डॉक्टर साहब. So they do not know what causes them jaundice. But biochemically, if we see, there is increase in bilirubin concentration, that is total bilirubin, which ranges from 0.2 to 1 milligram per dl. And this includes conjugated bilirubin, and the level of conjugated bilirubin can be in the range of 0. So as we have seen in the normal metabolism, conjugated bilirubin usually does not enter the anywhere in the pathway, does not enter very minutely, it might enter the systemic circulation. Unconjugated bilirubin is the major fraction which is present in the blood, as it is released from spleen to be conjugated in the liver. So that is a major fraction, that is 0.2 to 0.8 milligram per deciliter. So unconjugated bilirubin is also known as indirectly acting bilirubin, because it is water insoluble, first thing, and secondly, because it is bound to albumin, it requires methanol or ethanol to be extracted from albumin. So usually it takes longer time for unconjugated bilirubin to give color. That is why it is known as indirect. And conjugated bilirubin, because it is water soluble, it can directly react with Ehrlich's diazo reagent. So this, as we commonly, all of us know as Vandenberg reaction. So there is no requirement of addition of any organic solvent in this case. So when the serum bilirubin concentration rises above normal, this is known as hyperbilirubinemia, and the condition is known as it deposits in tissues which are stained yellow, and this condition is known as jaundice or icterus. So it is most commonly seen in skin and mucous membrane, but it is most commonly visible in the sclera. So when the level of bilirubin is between 1 to 3 milligram per deciliter, it is known as subclinical or pre-icteric jaundice. And when the level increases beyond 3 milligram per deciliter, it is known as icterus or jaundice. So in pre-icteric condition, the yellowish discoloration is visible, and the clinical presentations are usually symptomatic. The patient complains of abdominal pain, nausea, vomiting, anorexia, lethargy. And if the biochemical investigations are done, it shows an increase in the level of hepatic enzyme. But there may not be any yellowish, clinically no yellowish discoloration present in pre-icteric condition. So jaundice can occur in a number of diseases. Depending upon the site of disease, the jaundice can be divided into 3 types. As we all know, pre-hepatic, hepatic, and post-hepatic. The pre-hepatic, depending on the type of bilirubin present, it can be unconjugated or conjugated. Unconjugated jaundice is also known as retention hyperbilirubinemia due to overproduction, or acholeric jaundice due to presence of excess of unconjugated bilirubin. Then conjugated hyperbilirubinemia is also known as regurgitation hyperbilirubinemia due to flux into the bloodstream because of biliary obstruction, or choleric jaundice, that is water soluble, so presence of bile pigments in the urine, that is called as choleric jaundice. So there are 2 terminologies for prehepatic and posthepatic: retention and regurgitation hyperbilirubinemia. So if the serum bilirubin unconjugate, it exceeds, as we all know, 20 to 25 milligram per deciliter, the excess bilirubin is attached to the low affinity site of albumin. And this low affinity site is very volatile. It can easily dislodge from the albumin when any other compound like drugs, if they attach to the albumin, albumin is acting as a carrier. So these low affinity sites offload all of this bilirubin into the central nervous system. And because they are hydrophobic in nature, fat soluble, they can easily cross the blood-brain barrier, and this result in kernicterus or encephalopathy as it is seen. So encephalopathy due to hyperbilirubinemia kernicterus can occur only in connection with unconjugated bilirubin as found in retention. So if we see diagnostically, there are different types of bilirubin. One is unconjugated bilirubin, which is also known as alpha bilirubin; monoconjugated bilirubin, that is beta; diconjugated bilirubin, that is bilirubin diglucuronide, is gamma; and the fraction which is irreversibly bound to protein, normally albumin, is your delta bilirubin. When conjugated bilirubin level is very, very high, it can become covalently bound to albumin, which produces a biliprotein or delta bilirubin, and it is easily estimated because it creates panic among people that they are still treated, but they cannot, the yellowish discoloration has not gone. So conjugated bilirubin has a half-life of less than 24 hours. And delta bilirubin has a half-life similar to albumin, that is 17 days, which causes prolonged jaundice during recovery from hepatocellular injury or biliary obstruction. So that in this case, delta bilirubin is implicated because of half-life of albumin. So these are the usual biochemical presentation of different bilirubin. The normal level of serum bilirubin can range from this direct and indirect. Urine urobilinogen is 0 to 4 milligram in 24 hours. Urine bilirubin is completely absent. Then fecal urobilinogen is 40 to 280 milligrams in 24 hours. In hemolytic anemia, as is known as prehepatic, it is indirect is increased. In hepatitis, direct and indirect both are increased, which is known as biphasic response. And obstructive jaundice, it is direct is increased. Urine urobilinogen is increased in case of prehepatic jaundice, and hepatitis, it is decreased because of micro-obstruction. And in case of obstructive jaundice, urobilinogen is completely absent. In case of hemolytic anemia, it is urine bilirubin is absent. In hepatitis, if micro-obstruction occurs, it might be present. In obstructive jaundice, it is strongly present. And fecal urobilinogen in case of obstructive jaundice is trace or absent. In hepatitis, it is decreased. So these are the findings. So we can discuss prehepatic jaundice first. It is very different from other two jaundice because this is the only condition in which the bilirubin load is actually increased. Otherwise, in hepatic and post-hepatic condition, the load is generally normal and the bilirubin load is normal. So as the rate of breakdown of hemoglobin is increased, bilirubin is formed in such large quantities that the capacity of the liver to take up is lost, and it conjugates and excrete. Excretion is exceeded. So concentration of unconjugated bilirubin rises, but the level of conjugated bilirubin is also increased. So this conjugation is increased, so formation of urobilinogen is also increased, and this is known as hallmark of hemolytic disease or prehepatic jaundice. Because unconjugated bilirubin cannot be excreted through kidneys, urine will not contain the bilirubin. A common cause of hemolytic jaundice is physiological jaundice of neonates, and this occurs in some neonates between 24 hours after birth or 10th day of life. This is called physiological because it's a common phenomenon that occurs, physiological jaundice, because it occurs 24 hours after birth. If the child is born with the jaundice, it is known as pathological. The erythrocytes which are formed during fetal life, they have HbF, and it is rapidly destroyed after birth. And the second condition is breast milk jaundice. Breast milk may contain enzyme glucuronidase, so this it results in unconjugation of the bilirubin. So the rate of formation of bilirubin is increased, and as the hepatic conjugating system is not developed or premature in the first 2 weeks of life, unconjugated bilirubin accumulates and in blood, causing jaundice. This is, however, a transient or a benign condition. So usually it does not require any intervention. But if there is any reason, if the child is irritable or failure to thrive, intervention is required. So it can also occur in several other hemolytic disease. The most serious is your erythroblastosis fetalis, which usually occurs in Rh incompatibility in pregnancy. The father is Rh positive, the mother is Rh negative, and the mother is carrying a Rh positive baby. So at the time of delivery, the baby may, there might be crossover of blood during delivery. So the mother is now exposed to Rh positive blood. So she develops immunoglobulins, and these immunoglobulins being IgG, they can placenta. But the first child does not suffer. Is the subsequent pregnancies which results in erythroblastosis fetalis only if the baby is Rh positive. If the second child or subsequent children are Rh positive. So in central nervous system, the bilirubin is attached to what happens in unconjugated hyperbilirubinemia is the baby is born either with jaundice but may develop erythroblastosis fetalis or kernicterus, or may die in utero also, that is hydrops fetalis. So what happens when the unconjugated bilirubin level is very high? The low affinity site at the albumin will offload it into the central nervous system, and it is attached to basal ganglia, hippocampus, cerebellum, medulla, etc. And these are stained yellow. This is known as kernicterus, which is often fatal, and it leaves behind permanent neurological damage. The patient is going to survive. Then how do we manage a case of prehepatic jaundice? Usually, we do not see the level of unconjugated bilirubin. If the child is irritable or is refusing feed, or even if the bilirubin is not markedly high, the intervention should be done. And for physiological jaundice, usually phototherapy with blue light is advised, or barbiturates. In case of RH incompatibility, we prescribe blood transfusion, and after first pregnancy, anti-D to mother. That is the usual treatment modality which is given. Then in case of obstructive jaundice, which is also known as cholestatic, obstructive jaundice can be intrahepatic or extrahepatic. The commonest cause for intrahepatic is hepatocellular diseases, among which hepatitis, then drug-induced liver injuries, then carcinomas, etc. come into play. Extrahepatic, the most common cause is cholelithiasis, then carcinoma head of pancreas, because it is just behind the second part of duodenum, or carcinoma ampulla of Vater, stenosis of CBD by lymph nodes, atresia, stricture, etc. produce extrahepatic obstruction. Regurgitation, choleric or posthepatic, the flow of bile is disrupted. As a flow of bile is obstructive bilirubin, which has been reconjugated, conjugated in the liver, excreted in conjugated bilirubin is regurgitated in circulation. Being water soluble, it is excreted in urine. So post-hepatic jaundice, the typical feature we will see is conjugated bilirubin is not rising too much, because it usually is excreted by urine. So because it does not reach the intestine, urobilinogen is stopped. It cannot be formed, and urobilinogen will be absent in urine. But it also is absent from the feces. That shows the typical clinical features of post-hepatic jaundice of clay-colored stool, and mainly patient complaining of clay-colored stool. Now here the catch is that it is not just the bilirubin, it is the bile which is spilled into the systemic circulation. So the patient may come with pruritus, severe pruritus, because of deposition of bile salts under the skin, and relative bradycardia. So relative bradycardia is because bilirubin has an action very similar to digoxin. So the biochemical features that we see in the blood and in urine is conjugated bilirubin is increased, presence of bilirubin and bile salts in urine, and absence of urobilinogen in urine. But the color of the urine is deep yellow because of the presence of conjugated bilirubin in urine. Then hepatocellular, I'll just wind up fast. In hepatocellular, subsequent edema due to inflammation causes mechanical obstruction, significant damage to liver function is there. So interferences, because of the interferences in all three major steps of bilirubin metabolism, that is uptake, conjugation, and excretion. So any of these three steps, if they have is a problem, can produce hepatocellular or hepatic jaundice. So the liver abnormal rise or biphasic response is because liver is not functioning properly. Most of the time, only 50% of the liver is functioning. So there is increase in unconjugated bilirubin, and because 50% of the liver is functioning, so there is increase in conjugated bilirubin. Because excretion of the rate limiting step is usually impaired to the greatest extent. Conjugated hyperbilirubinemia will predominate. The conjugated hyperbilirubinemia is there because the conjugated bilirubin, instead of entering the bile canalically because of the edema, it is spilled into the central vein. And because it is spilled into the central vein, it will reach the systemic circulation. So both unconjugated and conjugated bilirubin is increased. Now there are certain conditions of heredity. I'll go very fast with them. I know the time is over and above. Hereditary jaundice, there are certain conditions where the uptake is defective, or the liver is not functioning properly, that is conjugation is not there, enzymes are defective. Then it is a possibility that these hereditary jaundice, means this is passed from generation to generation, may occur. First is Porter syndrome and Dubin-Johnson. These three conditions
Recording in progress.
Am I audible or not?
Ma'am, you are audible. Yes, ma'am, you are audible now. You can
Achha,
continue.
I was not audible all this time?
No, you were not audible for, I think, this slide only, the Crigler-Najjar syndrome.
Okay. Okay. So Gilbert's, as we have hereditary Gilbert syndrome, as we know, I have told you that the liver performs three functions. One is uptake, then conjugation and excretion. Defect in any of these three mechanisms can produce hereditary jaundice condition. And in Gilbert syndrome, it is a defective UDP glucuronide transferase, which is subnormal. So the concentration of unconjugated bilirubin is increased. And this is typically a condition which is autosomal dominant, and among hereditary jaundice, this is the only dominant condition. And to say about it, it is fairly common also. Since my MBBS days, I have seen 3 or 4 cases of Gilbert syndrome, and they are perfectly fine. They do not have any complications as such. Then Crigler-Najjar, this is autosomal recessive, and it is of 2 types, type 1 and type 2. In this, again, hepatic UDP glucuronide transferase activity is absent. The unconjugated bilirubin is greatly elevated, and kernicterus is common, and this disease is usually fatal. Bubble baby syndrome, as it is called. Then type 2, hepatic UDP glucuronide transferase activity is decreased. But this is decreased, not completely absent. So again, there is increase in unconjugated bilirubin, but it is not as fatal as type 1. Then Lucey Driscoll, this is basically congenital, seen in newborns, and it is usually considered to be due to maternal steroids which are passed through breast milk to the newborn, and this is an inhibitor of UDP glucuronide transferase, and this is again causes, it is also autosomal recessive, and this produces Lucey Driscoll syndrome. Then the 2 other diseases, Rotor syndrome and Dubin-Johnson, these are conjugated hyperbilirubinemic syndrome. So here, basically excretion is defective in both conditions, and they are autosomal recessive. Again, Dubin-Johnson is also autosomal recessive condition, and here a black pigment melanin is also deposited in the liver. It is very similar to Rotus. It is again autosomal recessive. So I'll wind up my slide. Thank you so much, ACCLMP, for giving me this opportunity, and Rajasthan chapter for providing me this platform to share my take on jaundice. Thank you so much. Thank you so much.
Thank you so much, Shuchi ma'am, for taking your valuable time for sharing your knowledge with us with a nice presentation. Now, for the questions and queries, I will request all the audience to kindly text it in the chat box, and we will try to take it after the panel discussion altogether. And also, you should mention the name of the speaker or the panelist whom you want to ask the question to. And if time permits, we will take up the questions all together. Otherwise, you can also send your queries to the mail acclmpofficial.com, which has been given in the website. So starting with the panel discussion now. I am very honored, and I really will take privilege to introduce our moderator, Dr. Lieutenant Colonel Arun K. Harith sir. Where I know that he does not need much mention still. He actually is the president of ACCLMP Delhi chapter. He is an MBBS and MD from Biochemistry from AFMC Pune. He has served good 23 years in military and has retired as Lieutenant Colonel. He is presently working as senior consultant and head of the Department of Pathology and Laboratory Medicine in Medanta, the Medicity, Gurugram. His areas of interest are lab automation and biochemical genetics. He also is a very passionate teacher and holds a YouTube channel dedicated to biochemistry and laboratory medicine. He's also trained in pathology and microbiology and transfusion medicine from the AFMC. So over to you, sir, for the further process.
Thank you. I thought the catchword was a very short introduction, and it should have been kept that way. Ma'am, could you just make me the host or a co-host so that I can, there, I've got that.
Yes, sure.
Just a second. Just 1 second, hang on.
Yes, sir.
सोनी तरफ है फोन बज रहा है। नहीं सोनी का फोन बज रहा था।
Sir, can you please unmute yourself, sir? Kindly, yes, sir. Okay.
Till now, I was well settled, and last minute there's something or the other that happens, and that sets the tide off. Right. F5. Right. Is the first slide on?
Yes, sir.
We can.
Very good. Today is a very interesting topic, and a lot of issues about the liver diseases in terms of bilirubin homeostasis, in terms of the transaminases in great details have been covered, and that's actually setting foundation to the procedure. Now, as a biochemist, the big success story that we tell ourselves is that in the 60s and the 70s, when the liver biopsy was the gold standard for diagnosis of any liver disease, and that had its associated risks and trauma to the patient. We came with a set of investigations that practically replaced liver biopsy. And that was possibly a big claim to success. We really need to rethink ourselves over the years. Are we on the right track? Is this very good? Do we have something more to add? Do the clinicians actually feel that this is comprehensive or not? Yeah. So to help us in understanding this whole process, I have a group of very esteemed panelists. The first one is Dr. Bidi Tura. I know him personally because he actually displaced me out from this college, Army College of Medical Sciences. Started off as the head of biochemistry, went on to become the officiating dean. He's got a very illustrious career in the field of education. He's been the professor and head of Department of Biochemistry, ESI Alwar. He's in the World College of Medical Sciences, Haryana. He's been the officiating dean of Army College of Medical Sciences. This is one of the prime colleges in Delhi. Vice principal of Arupadi Vedu Medical College in Puducherry. And needless to say, a man with such a stature would have numerous national and international publications. He's been very modest in not enumerating them for sheer space occupying. The next panelist we have is Dr. Neera Samar. She's the senior professor in the Medicine and Acclmp Medical College, Udaipur. Her key areas of interest have been in lifestyle diseases, infectious diseases, pharmacovigilance, and keen worker in the field of HIV. She's a nodal officer for the ART Center in the R&T Medical College. Ma'am is here to share with us her clinical insights about the liver function test as the clinicians see it. We see the liver function test purely from the biochemist's eye. We would get some clinical input onto this. Dr. Jamil Mohammed, he's the General Secretary of the Acclmp Rajasthan chapter, a very young, dynamic person, quite inspirational to talk to. He's, as of now, the assistant professor in R&T Medical College also. He's done training in quality management systems, in basic course workshops, curriculum implementation, published in a lot of national and international journals, and has got some keen interest in recent advances. And while brainstorming this whole session of the workshop, when I was interacting with him, he had a lot to teach me, and I had to tell him, boss, let's wait for the workshop, let's wait for the panel discussion, let's go on to that. Dr. Shikha Panwar, she is the senior consultant radiologist and head of MRI division of the Mahajan Imagings in Delhi NCR region. She is a graduate from the Armed Forces Medical College, Pune. She's done a post-graduation from the Army Hospital Research and Referral in Delhi. Both of them are premier institutes. She has expertise in onco imaging, publications, book chapters, conferences, reviews of guides to PG students, the works, you name it, she's got it. She did want me to add a lot of stories to her, keeping a very low profile. Group Captain Preteen Kinra, a UG and PG from Armed Forces Medical College, a UNIF topper in MD path. He's been trained in biochemistry and microbiology at AFMC. We were sharing a common place in the biochemistry department in AFMC. He's been trained in GI pathology from AIIMS, Pune. He's got a WHO fellowship in molecular pathology. For professional excellence, the Chief of the Air Staff has given him commendations, and a good combination of being an undergraduate student, postgraduate student, and then a professor at Armed Forces Medical College, and now at Army Hospital R&R. He is going to give us the pathologist perspective of liver function tests and the areas where nobody has an answer and where he comes with an answer. So the way we plan to conduct this panel discussion is, first, Dr. Tura will be talking about what is there in the liver function test as we see of today. Then we'll take insights from Dr. Neera ma'am as to what are the key areas of lacunae in the existing liver function test where they need to resort to imaging techniques for assistance. Dr. Shikha will be telling us about the various imaging modalities and what kind of useful information they provide to the clinicians to manage the patient. Dr. Jamil and Dr. Shuchi ma'am will be talking about what are the recent advances in the biochemical tests, the tests which are either in the research domain or tests which are available but not universally being followed, but which have potentials to augment evaluation of liver function tests. After these discussions, we will have a brainstorming session. Sorry, my introduction was a bit long, sir. Please take the stage, sir.
Thank you, sir. Am I audible?
Very much.
Okay. So, sir, first thing, thank for your nice wording. And one thing I want to correct, I have not displaced you, but you have given a chance me to serve in the Army ACMS, sir. So with these corrections, I will start my talk. And my talk has been simplified by the two already speaker which has given talk on AST, ALT and jaundice. So most of the liver function test, you can see, it can be covered in these talks, and you all must have come aware what are the liver function tests. But still, as a part of the panel discussion, I will just go very fast as we are running short of time. So I will try to finish within a very short periods. Next, sir. So as first we should know what are the main functions of the liver. So liver, as we all know, being a biochemist, liver is having synthetic function, liver is having detoxification and excretion function, and then liver is having storage function, and then liver is having productions of the bile salts and others. So that are the basic major functions which are associated with the liver. Now, after seeing the major metabolic function, so what are the common diseases which are associated with the disease, with the liver? So the common liver dysfunctions or liver disease which are associated with liver are hepatocellular disease, cholestasis, which is due to obstruction of the bile flow, and cirrhosis of liver, hepatitis, jaundice, liver cancer, and steatosis, which is a liver disease, and genetic disorder, which is associated with the iron metabolism, and it is a hemochromatosis. Next, sir. So, if we say the liver function test, it is a non-invasive method of the screening of the liver liver dysfunction, and it helps in identifying genotype of the disorder, and it helps to assess the severity and allow prediction of the outcome of the disease and treatment follow-up. That is the importance of the liver functions. And what are the liver functions? So that we can classify broadly into two. What that is, for number one is test to detect the hepatic injury, and the number two is test to assess the hepatic functions. So then what are the tests that can be classified into three categories? What are these categories? These are the one group. One is a marker of the liver dysfunctions. So marker of the liver dysfunctions are liver, serum bilirubin, it is a total and conjugated. Then total protein again include albumin and globulin and Ig ratio. Then prothrombin time, and the urine test for the bile salt or urobilirubin. Okay, and group 2 are the marker of the hepatocellular injury, and these are the enzymes which are produced mainly by the liver. These are ALT and AST. And number third group is, next sir. Third group is there, which is a marker of obstructions in the liver biliary passage or cholestasis that are alkaline phosphatase and GGT. So these are the normally liver function which we talk in our day-to-day teaching activity. Apart from that, some other functions are also there that will come later on. So next. But this liver function tests are having its limitations. So what are the limitations? So even person is having liver disease, but there may be a normal LFT values. That is possible because liver is having very large reserve capacity. Due to that only, that is possible. And another condition may be there, the patient is having asymptomatic, but there may be some abnormal LFT result when the investigations are done. So that is why whenever we have to see the disease, we should liver function test. We should see the clinical condition of the patients. Then normally, what are the tests? What are the importance? That only just in brief I want to discuss the AST, ALT. That is for hepatocellular damage. And bilirubin is for cholestasis and impaired biliary obstruction. And alkaline phosphatase, again, it is for cholestasis and infiltrative disease. And prothrombin time and albumin both are for the synthetic function of the liver. And GGT, gamma glutamate transferase, that is, and bile acids, that again for the cholestasis and biliary obstructions. So this bilirubin, I think I should skip this because already in detail speaker has been discussed. So I should skip this, and urobilinogen also she has covered in that topic. So considering the time, so but only we should know these bile salts are only seen whenever there is obstructions to the biliary passage. And serum albumin, that are total protein, these are again for the synthetic functions of the liver, and the normal value I'm not going to discuss, but definitely what I want to stress, liver albumin or total protein, that is only significance in the chronic liver disease, not in the acute liver disease. Next sir. And these again albumin globulin ratio, whenever there is a dysfunctions chronic disease and globulin ratio increase, so to compensate that only. And prothrombin time, that is there again required to find out the synthetic functions of the liver. And proton time is prolonged only when liver loses more than 80% of its reserve capacity. That I want to stress this. And this prothrombin time can also be increased whenever there is a vitamin K deficiency. But whenever there is a prothrombin time increase due to vitamin K deficiency, and how you can differentiate prothrombin time is due to vitamin K deficiency or liver disease. If you are giving the vitamin K deficiency in liver diseases, it will not affect the prothrombin time. Next, sir. So, and AST and ALT, that already in detail Dr. Shiva has been discussed, and these are the enzymes which are synthesized mainly in the liver and increase during the liver disease. And now coming to the alkaline phosphatase, alkaline phosphatase is basically a non-specific marker for the liver disease because it is also synthesized by the bone also, and that is why it is not specifically for the liver disease. And but moderate elevation of the ALP is observed in next slide. That is a no sir. That I observe in infective hepatitis. Infective hepatitis, alcohol hepatitis, and hepatocellular carcinomas. That is the significance of estimation of the ALP. And next, and high level is observed in obstructive jaundice and intrahepatic cholestasis. And very high level of this ALP is seen whenever there is a bone disease. Next slide. So this gamma glutamyl transferase, so that is elevation of this GGT is seen in infective hepatitis and prostate carcinoma, and this GGT is increased in alcoholic despite normal liver functions. That is also possible is there. And it is highly sensitive for the alcoholic disease. And normally when we are teaching in the to the students, we talk up to that only. But nowadays, for the clinician point of view, the other marker which are now included in the liver function test are the marker for the hepatitis also. What are the marker for hepatitis? For hepatitis A virus, there is a IgM and IgG. And for hepatitis B, it is a surface antigen and antibody and core antibodies that are for hepatitis B. And for hepatitis C, it is again a antibody, surface antibody, which is help in detection of the different type of hepatitis. Next. So then in the hepatitis, whether our enzymes are increasing, so AST, ALT are also increasing in hepatitis, which help in the diagnosis of the hepatitis. Then tumor markers are also there, which help in to find out the liver carcinoma. So normally there are 3 tumor markers which help to find out whether the person is suffering from the liver tumor. And these commonly tumor marker which are undertaken in the biochemistry are total alpha fetoprotein AFP, and then there is a AFP L3, then there is a protein induced by vitamin K or antagonist 2, that is PIVK2. So these are the tumor marker which are specific for the to find out liver malignancies. So with these, all the common liver function test, but these the test, we can, most of the liver disease we can diagnose. Now, for whether other investigations are required, that will be discussed by other panelists. Thank you, sir. Sir, muted. You are muted.
So whenever a patient comes to us, the first thing that is done is that we ask for a liver function test, and the liver function test, as sir has elaborated, we check for the metabolic or the detoxification function of the liver. We check up for hepatocellular injury. We check up for alcohol induced, which is probably the most common run-of-the-mill diagnosis that we get. These Hello. Ma'am, can you hear?
Now we can hear. Yes, sir.
Yeah, as I was saying, that the liver function test that we do cover up the basic detoxification function of the liver, the synthetic function of the liver, the hepatocellular injury, and now we have obstruction, and now we have viral markers also. So with these investigations, Neera ma'am, are you satisfied, or do you identify certain areas where these tests are lacking?
Hello.
Yes, ma'am. Can you hear?
Yes, yes.
Are these tests adequate, or do you find that there's something more required in these?
Usually, whenever we have patients who are subjected for liver function tests, either in a routine screening, like in this era of medical checkups, which are routinely done, or with the history of liver disease, that is, patient is having manifestations of liver disease. In a case of jaundice, you are subjecting them. So routine tests of these AST, ALT, alkaline phosphatase with GGT, etc., and profile of viral hepatitis, they are all adequate. But as a routine, you have to take a very elaborate history in all the patients regarding past history of jaundice, or the history of intake of IV drug abuse or alcohol, or history of travel for hepatitis E or A, then history of blood transfusions in the past, or promiscuous sexual activities, etc. So if you find that liver function tests alone, these routine tests, they are not good enough, we can subject the patients to further extended profile, including anti-mitochondrial antibodies, including serum transferrin levels and saturation of transferrin, serum ferritin levels, and then ceruloplasmin levels, etc., with the routine liver function tests. But finally, we always have to go for imaging of the liver to know the extent of the disease, because all these liver functions, they cannot depict that how much, whether the disease is diffuse in the liver or it is a focal disease in the liver, how much is the necrosis in the liver, or if it is cholestasis, then whether it is extrahepatic or intrahepatic cholestasis. So it is the need of imaging later on. And nowadays, many new markers of fibrosis. So if a patient is of chronic liver disease, you need fibrosis, or you need imaging of fibroelastography. I think that will be discussed.
You are muted.
Ma'am, unmute yourself.
Neera ma'am.
Neera ma'am, please unmute yourself.
50%. Oh, you have not heard me at all?
No, the last bit we didn't hear it.
Okay, okay. So even many times we find that serum enzymes are normal, but patient is having clinical condition of cirrhosis. Or many times patient present to us with end stage renal disease, but there are only mild elevations of AST or ALT. So you do not know, okay, how much is the extent of the damage into the liver. And the fibrosis is a process that goes on in chronic liver disease, which includes host genetic factors along with the microenvironment of the patient, with interaction of the fibrogenesis and the release of inflammatory cytokines or adipokines, etc. So it is the need of the hour that we have to subject these chronic cases mainly to the radiological imaging. And many times for cholestasis also, you have to know whether it is intrahepatic or extrahepatic, cause you need ERCP or MRCP, etc. in those cases. So even a US ultrasound Doppler can give a knowledge of diffuse liver disease and vascular study of the liver. So only liver function tests alone cannot suffice. And we are fortunate enough, I feel, that we are living in this era where we used to diagnose liver disease with few investigations of the blood. And now we are having such advanced techniques like FibroSure or FIP4 or transient electrography, etc.
So what I understand from this talk is that the first step towards evaluating a person with a liver disease is a thorough clinical history and a clinical examination. A liver function test adds a lot of information about patient management, but there are a lot of lacunae which the standard liver function test is not covering. And as I understand from what you've elaborately said, that if it's a chronic disease, if there's associated with fibrosis and to evaluation of the extent of tissue damage, the conventional tests are not very good. And that's when you resort to the imaging modalities to augment your clinical suspicion. So,
Yes.
Shikha,
One
I
more
would.
thing I would like to add, drug history is very important.
Yeah.
Drug intake, history of drug intake to know the drug-induced liver injury is very, very important, which we usually miss. Even common antibiotics like macrolides, etc., even amoxiclav combination, oral pill intakes by the patient, nitrofurantoin, these anti-epileptics and anti-tubercular drugs, which are commonly implicated. So drug history also should be very elaborate in these cases, which are a very common lacuna that is left behind in the history taking.
Yeah, so drug history is also definitely important. So we have with us Dr. Shikha Panwar, a very close friend of mine, and she will be taking on the common indications that she gets referrals for imaging in liver pathology, liver diseases, and elaborate a little bit more onto the details, because we really don't understand what is happening in those technologies and what the results are giving. Just a word for all the speakers. In case we hear a background noise, I have the ability to mute all the speakers. Unfortunately, you also get muted. So please be, when you hear some background noise, just look whether your voice is on or not. Right. So I hand it over to Shikha.
Yeah, thanks, Dr. Harith, for your lovely words. And I'm audible. Am I audible?
Yeah, you're very much audible. Is the slide visible?
No, slide is not visible.
Just a minute. I really don't understand what's happening on here right now. Just a minute, just a second. The next. Oh shit. Sorry.
Never mind. Never. Even if the slide is up, it doesn't matter.
There is this presentation. I have it with me ready. We can see that.
Yes.
Yeah.
Bingo, yeah. So, as you mentioned beautifully, and the speaker before me, that the radiology department always works in tandem. You know, we are actually diagnostics where the lab and the radiology works together. So a lot of lacunae which come out of the tests, the blood tests, we fulfill, and whatever we are lacking, you fulfill. So we are all working in tandem. So getting back to imaging of the liver, the common clinical indications for which people come to us for imaging of the liver are number one, when they are symptomatic. That is, they may be having abdominal pain, nausea, vomiting, fever, any such thing, gastritis, any such thing. That's one major chunk of patients. The others are asymptomatic patients who come for health checks. As health checks, you know, everybody is very, very clued up about their health, and after 40 or after 50, they want to come for health checks. So liver imaging forms a large part of that. And that's when a huge bunch of, the non-alcoholic fatty liver disease gets diagnosed, the NASH, these kind of things for which patients are asymptomatic get diagnosed. Then there are other set of patients who are asymptomatic, but they have deranged liver function tests. So that's when, again, we step up to find out if there are any cause for the derangement of the liver function test. There are the next group of patients which are follow-up, patients who have cirrhosis, who have mass lesions in the liver, who are, mitotic lesions, metastatic lesions. They are on targeted therapies. They come to us for follow-up. They form a large chunk of patients. And then there are people who come as part of a pre-transplant workup, which are those liver donors. So they again come to us for workup. So broadly, these form the clinical indications for which we image the liver. As all of you are aware, the routine modalities that are available are ultrasound, CT, MRI, and PET-CT. These form the basic conventional group of imaging. Ultrasound is the bread and butter. That is the first line of investigation, followed by a CT and MRI. Now, CT and MRI have been present since a very, very long time. A lot of advancements have happened in them. We have fantastic equipments, so we do a whole bunch of dynamic CTs and MRIs, multiphasic. And the importance of these multiphasic studies is that nowadays it is said that the criteria have come up where in situations like an HCC, when an HCC is suspected, we do not need to resort to a liver biopsy. If we do a CT and MRI and on two dynamic modalities, we are fairly certain and our degree of suspicion is very high that this is an HCC, then a liver biopsy, it is not resorted to. The caveat to this is that we know that the tumor marker, which is specific for HCC, which is the serum AFP level, may not always be deranged. There are, I think, about 30 to 40% of cases where the AFP may be normal. That's again where we step in on the imaging. We may we categorize the lesions towards the degree of suspicion that we have, which we call the LIRAD score, which is from 1 to 5, and when we are fairly certain, we give it a LIRADS 4 or a LIRADS 5 in a backdrop of a cirrhotic liver, and we are then certain that this is a mitotic lesion, irrespective whether the serum AFP is borderline or sometimes not even deranged. PET-CT, of course, comes in for assessment of metastatic diseases and basically to stage metastasis elsewhere in the body. Now, these are the gamut of conventional imaging. As far as the advanced imaging is concerned, a lot of progress has taken place. And there are these two important things which I'm going to speak, a couple of minutes on, is elastography. And, you may be hearing a lot about fibroscans. Now, what are fibroscans? Fibroscans are done on two modalities. One is an ultrasound-based fibroscan, and the other one is MR elastography. And we also use CT and MRI for liver iron and fat quantification. So we not only assess it, but we can also quantify it now. So etiologies, everybody has discussed, we look at diffuse liver diseases, we look at focal liver diseases, so I'm not going to get into this. I'll quickly move on in the interest of time to elastography, which is actually the buzzword here today. Now, some 20 years back, liver biopsy was the only way in which we could assess what was going on inside the liver parenchyma in terms of fibrous tissue. Now, why do we need to assess fibrous tissue? We know that increased deposition of fibrous tissue within the liver leads to development of cirrhosis and its sequelae. And this happens in a whole bunch of chronic liver diseases, and which starts the process of portal hypertension, hepatic insufficiency, and of course progresses to HCC. So not only it's important to diagnose fibrous tissue in the liver, it is also important to stage the fibrous tissue, because this fibrosis in the liver progresses from no fibrosis to mild, moderate, severe, and to a frank cirrhotic state. And why is it important to stage the cirrhosis? Again, it's important because it prognosticates the status in which the patient is, because it's important, then to do surveillance, whether, what sort of a treatment a patient needs to be given. So we can prioritize his treatment and we can see whether there is any potential for reversibility of this fibrosis or not. And as we all know that the process of fibrosis is dynamic, and studies have now shown that regression of fibrosis is possible if we treat the underlying condition, which may happen in many cases, may not happen in other cases. For example, if antiviral therapies are given now for viral hepatitis, or immunosuppression is given for autoimmune hepatitis, there is a degree of regression in the fibrosis that may happen. And we on imaging can then assess that, follow up, and quantify it. So why do we want to non-invasively assess liver fibrosis and not straight away go for liver biopsy? Although liver biopsy is actually the reference gold standard for fibrosis assessment and staging, because it allows very, very specific grading of the steatosis, necrosis, and inflammatory activity. However, biopsy, as in all biopsies, it's an invasive technique. There is potential, for complications, which sometimes can be very severe in up to 1% of cases. And at the same time, there is a potential for sampling error. And by sampling error, we mean that, there is diffuse liver disease. You are sampling a particular area in the liver biopsy. Now, in the cores that are obtained, may or may not, assess or stage the fibrosis correctly, because in that particular sample, the diagnosis may not be accurate as compared to some other area in the liver. And of course, there may be inter-observer variability from a pathologist to pathologist, so that sort of an error is there with liver biopsy. When we use non-invasive methods for liver fibrosis assessment, this kind of error can be, circumvented. We need not go in for a liver biopsy, which I said, which is a very invasive technique. So, liver fibrosis assessment in imaging has been an intensive field of research, and we are continuously evolving. There are, increasing consensus papers which are coming out, and to a large extent, what we do as far as elastography is concerned, I'll just go into it into a minute later. And first of all, I would like to say that why do we want to, do elastography and assess what the stage of fibrosis is? When we do an ultrasound or an MRI, the best use for this elastography is to identify patients who have no or minimal fibrosis, which is a score of F0 or F1, and distinguish those from very severe fibrosis or cirrhosis, which is F3 and F4, because the management in both these sets of patients is different. So it's very, very important to categorize and to find out which category the patient falls into. So when we take the patient on ultrasound, which is the fibroscan, what we do is basically there are these, we assess the plasticity of liver. So there is a shear wave which penetrates the liver parenchyma. We take the patient on an ultrasound machine. We we use target areas in the liver, as you can see here, and we obtain multiple readings through different parts of the liver parenchyma. We are careful in excluding blood vessels and biliary tracts. We place tiny regions of interest. As you can see here, this is a region of interest where we have placed. We place this at about 10-12 locations, and we obtain scores. And the scores that we obtain are, are two kinds. One is we obtain the shear wave velocity, which is in meters per second, and the others we obtain the pressure, which is in kilopascal units. And once we obtain these 10 readings, we can quantify. The machine automatically computes it and quantifies it and gives us a value. And when we get this value, we score the liver stiffness, the liver tissue stiffness, which is known as the METAVIR score, where we range it from F0, which is there is no fibrosis at all, to F1, where there is mild fibrosis, F2 is moderate, F3 is severe, and F4 is where there is frank cirrhosis. And this is the range of values. So it's fairly simple. We just need to have that modality with us. We make the patient lie down. We obtain these scores from 10 different areas which we sample, and the machine automatically gives us these readings. And then we can just quantify and categorize the patient into one of these. And of course, there are limitations to the fibroscan that we do, as in all modalities, which being that if the patient is very obese, when there is gross ascites, then there might be, the readings might be inaccurate, because after all, the ultrasonic waves have a certain depth through which they can penetrate into the body. And when there is a lot of fat, abdominal fat, and the patient is very obese, and our depth is not reached, of course, then the readings are inadequate, and we may just obtain readings from the superficial part of the liver. So these are some of the limitations of elastography of the ultrasound, which again then can be circumvented by an MRI, because MRI, the patient obesity and these factors are circumvented on the MRI. MRI, utilizes a different method altogether when we do MR elastography. Again, there is a specific software with the MR machines, which is an expensive software. Every machine may not have it. And when you have that software, what you do is you make the patient lie down in the MRI, you obtain these specific sequences, and then, like the ultrasound, you drop regions of interest in various parts of the liver and take 10-12 readings, and automatically the machine computes and gives those values. And then likewise, we can score the patient into 1, 2, 3, and 4. So this is quickly what elastography is all about. And with the advent of this scan, it's a fantastic non-invasive way to assess liver fibrosis and assess chronic liver diseases and quantify. And the clinicians are very, very happy with this. It's a simple test. Patients come to us, we quantify, goes back to the clinician. Wherever an intermediate therapy can be given, that is given. Then we check for reversibility, and so it's a very nice and fine technique. So that's that I have in my gamut, and I'm open to discussion. Thank you so much. Dr. Harith?
As I kind of understand that a person gets a liver function test done, you find that the albumins are low, that's a chronic liver disease. You want to assess whether this is early stages or whether it's progressing to fibrosis and what is the extent of fibrosis. All those things which the standard liver function test does not give. The imagings give a much clearer delineation, identification of the disease, and clearly identifies where the fibrosis is high, where the fibrosis is not high. And as you said, that this has got implications in management of the patient. That is great. But obviously, we've talked a lot about the liver biopsy and the traumatic experience of the patient and the potential complications of it. But still, there are a lot of gray areas where neither the standard liver function test nor a radiological test would be coming to a conclusive diagnosis, and everything is tested on the altar of the eternal truth, that is a liver biopsy stroke cytology. I'm sure this field has evolved a lot, and it's probably not as frightening as we think it is. Group Captain Kinra, could you just throw lights on what is there? When do you get cases referred to you for a biopsy, and how safe or how scary is the whole process?
So good evening. Am I audible?
Yeah, very much.
Okay. So first of all, a very big thanks to Dr. Harith, who's been my mentor for last 3 decades now. So yes, that's why the point is coming to that. When every doctor starts shutting a door into a face of a patient, especially with a person having jaundice, and when other modalities of diagnosis are not helping him out, and that's the time the patient lands up with the pathologist with a liver biopsy. Although the liver biopsy has been painted to be a very gory kind of a procedure, I've done it myself. Yes, it does have a certain amount of issues. That way, if you see, we do so many maybe minor operations in any surgical field. However, but if we have a better modality to treat, to diagnose a patient, why not? But as we were discussing, there are certain set of patients. Very typically, I'll tell you what is the indication of doing a biopsy is unexplained transaminitis, when the radiology is not able to actually pinpoint as to what's going wrong with the patient. Second very common cause is there's something called as a cryptogenic cirrhosis, where you do speak about cirrhosis happening. There are nodules, but you're not landing up with the cause of a cirrhosis. Third very common is, which basically is seen in this unexplained transaminitis, is an autoimmune hepatitis. Autoimmune hepatitis was a kind of an unknown entity probably 30 years back in our country. But as we have evolved in the field of gastroenterology, you would have realized now we do keep picking up these patients. There are certain diagnostic modalities in biochemistry which can help you in diagnosing autoimmune. But many a times when you have a person having features of chronic hepatitis, serology is missing, and none of your common autoimmune markers are coming positive. That's the time the GE physician goes in with a needle and asks us to do a scoring of autoimmune. That's called an AI score, which is scored out of 15. I would not go into details. It will be shared with you after some time, where basically there are 5 places in the liver biopsy which we are basically looking for. There's a clinical score, there's a biochemical score, there's a pathological score, there's an autoimmune score, and there's a history taking score. So you're going to add everything, and that is how you fine tune and give a person a diagnosis of AIH. AIH clinically many a times has an overlap with NAFLD. It is not a must. Please do not take home this idea that anybody who's obese and has got a sedentary lifestyle lands up with NASH. There are patients, that 20 to 25% of patients who do not have an overt metabolic syndrome, but still are suffering from a non-alcoholic fatty liver disease. So these rare modalities, yes, the word is rare, maybe out of 100 cases of transaminitis, there'll be 1 to 2 which are unanswered by other modalities. That's the time that you require a biopsy to be done, even in today's parlance. But what's more common is in the surgical field. Now, as my previous speaker, Dr. Shikha, said that for hepatocellular cancer, there are very specific laid down diagnostic criteria given in radiology, and I agree with her. However, there are many other tumors which do occur in liver, which still need to be characterized with the cells, stroke tissue, so that the appropriate level of treatment can take place. And with the molecular classification coming up for hepatic adenoma, there are 4 types I'm not going to detail. Even the treatment modalities change, and imaging or any kind of a routine biochemical test will not be able to tell you whether these hepatic adenoma is of a particular type. Same thing goes with certain cystic diseases of the liver which are malignant. But the most common place where we are asked to come, not with a liver biopsy needle, but with a fine needle aspiration needle, is when we are having a patient of cups. That means we have metastatic nodules coming up in the liver, but you do not know where the primary is. So this is the time you need to go in with a fine needle, hit the lesion. Normally it is ultrasound or CT guided, and you make up cell blocks. So that so-called trauma which is associated with the liver biopsy is not there. The trauma is minimized. And that is many a times we get to know that yes, this patient is actually a patient of prostate cancer just because it was a small nodule which has thrown meds here and there. So this is very common with the needle. Ever since you've got a cell block preparation, that means you can make a cell block out of the needle aspirate. You can even do an immunocytochemistry and characterize and tell exactly what type of metastasis is. As the GE physician of the panel also spoke on, that there's a very common entity called as DILI, or drug-induced liver injury. Now, although we keep talking of history taking, but actually all of us would actually know about that we do not have time so much for history taking, and we do miss on drug history. So in case we are biopsying a person with unknown transaminitis, as I told you, or an altered liver function is being biopsied with no diagnosis known, DILI, that means there are certain set of drugs which will have different kind of histological patterns. So when we list out the biopsy report, one of the differential is DILI, and based on pattern, we even give a panel of 9 common drugs which can give that reason. So it could be a drug which can cause steatosis. There are a set of drugs which cause granulomas. There are a set of drugs which cause fibrosis, which are absolutely similar to chronic hepatitis. One more role before I end is very commonly used is in liver transplant. So before a person goes for a transplant, the donor's liver is actually biopsied. In fact, it is done not truly intraoperatively, but just before the liver is transplanted, if it's an emergency transplant, and that's the time you need to characterize the amount of steatosis in liver of the donor, because there's no point taking a liver transplant from a diseased donor and giving it to a recipient. And not only that, after the liver transplant is done, there is a set Banff criteria which can actually tell you whether the patient is having a hyperacute rejection, acute rejection, and if it is happening, because there's a lot of difference in a rejection treatment and a treatment of some other kind of chronic hepatitis. So in a rejection, you need to give high dose steroids, but whereas suppose it's a recurrence of an infection in a recipient, you're not supposed to give steroids. And the last very important reason where a biopsy is done in a liver is in a neonate. A 6-month-old child typically comes with cholestatic jaundice, if not cholestatic, with deep jaundice. And the first thing the pediatric gastroenterologist asks us that he's concerned whether it's a biliary atresia or it's a giant cell hepatitis, which is common in neonates. That's the time we actually do a small needling procedure, which is actually a fine needle. And picking up a neonatal giant cell hepatitis is very simple on needle. The moment you tell them it's a giant cell hepatitis, it goes into medical management. And if it is a biliary atresia where you do have imaging modalities, then it goes into a surgical node. Very rarely you have metabolic syndromes, although we keep talking of ectopic markers which are there in serum and plasma, which are there, but still many a times I've seen the pediatricians walk up to us and asking us for a biopsy result so that we can characterize a type of storage disorder. And I think so the only one thing that I've left is that in imaging, sometimes it becomes very difficult to differentiate a regenerative nodule and a very well differentiated hepatocellular cancer in early stages. Maybe at that time, yes. So yes, I do agree that the role of liver biopsy has reduced over last 5 decades, but these are certain places where when you are against the wall, you're still required to do a biopsy. Dr. Harith, I'm done with my talk.
First and foremost, pretty reassuring to know that a liver biopsy or a liver cytology is not as gory and as scary as it was in the yesteryears. Pretty interesting to know that you could get some amount of tissue, make a cell block, and then subjected to most of the immunohistochemical changes, stainings, which would probably be as good as what you'd be seeing in a biopsy. So that's great. What I've understood from Shikha's talk and Dr. Shikha's talk and your talk is that fibrosis is not the key indication for a liver biopsy study, which used to be the yesteryears, but there is a whole lot of indications where still one has to resort to the liver biopsy. It also comes to highlight here that when you're talking about neoplastic lesions, what we have at best is the AFP, and the AFP does not give too very many answers. So now, from a pure biochemist point of view, have we really changed our liver function test? Are we still stuck up with the good old bilirubins and the proteins and the transaminases, alkaline phosphatase? Or are there some markers which are available right now? Maybe research, maybe not commonly used, which can predict fibrosis, which can talk about cancers. Are there something onto that? Will any of the panelists take it over?
Yes, sir.
Tell me.
Yes, sir. As the biochemistry is evolved and advanced, and like some limitation in the biopsy and as well as in the radiological imaging, as Dr. Shikha was telling us the limitation of biopsy as well as radiology. Even MRI is a best alternate, but it have its own limitation, like very obese patient can't fit in magnetic bore, and there is a claustrophobia, then severe hematochromosis, and definitely the cost of the test. They are the limitation in, and sometimes because in chronic liver disease they require repeated evolution of the fibrosis, and the effect of the treatment, they require repeated evolution. So in that case, liver biopsy can't play, and even radiology have limitation. And as new biomarkers are there, they are. I'm very sure. I'm saying it that they are the biochemical tests are not alternative, but they can help the physician as well as the patient. And for fibrosis, they are having new markers. Some are well established and some are promising, very much promising, and can be used. And they are all already available in the market and immunoassay platform. And they are divided into direct marker, class 1 marker, which are like they are related to fibrogenesis or process or fibrodegradation process, and indirect marker, which are more or less related to liver markers. in direct markers, some are really very promising, like hyaluronic acid, which is a glycosaminoglycan, and it contains, it is a part of ECM and synthesized by hepatic satellite cell, and it is the best class 1 biomarker found to be so far, with the area under curve of 0.97, and negative predictive value is almost 100%, but positive predictive value is less. So it is used to rule out the fibrosis, especially rule out the fibrosis, the hyaluronic acid. Then the second best is type 4 collagen, which is component of ECM, and it is used to be surrogate marker for liver fibrosis, and the cutoff value is 5 nanogram per ml, and it has area under curve of 0.82 around, and it is used for detection of fibrosis. But if it is used with combination with procholinergen type 3 N-terminal peptide, its sensitivity and specificity increases up to 90%. Procholinergen type 2 N-terminal peptide is also useful, and procholinergen type 1 C terminal peptide is also useful. Some other promising marker for fibrosis are laminin and BiKL40, which is also known as context, which is member of chitinase family, and its role in remodeling and degradation of ECM. The cutoff for contracts is 330. Above that, it gives the excess of fibrosis, and but it is not best. HA and is better than contracts. Some other like matrix metalloproteinase, they are the indirect markers. Direct biomarkers, matrix metalloproteinase and tissue inhibitor of matrix metalloproteinase. Especially matrix metalloproteinase are which are used is MMP2 and MMP9, and tissue inhibitor. There are two inhibitors, TIMP1 and TIMP2. TIMP1 binds to all matrix metalloproteinase, and TIMP2 is specifically with type 2 matrix metalloproteinases. TIMP level increases in chronic liver diseases, and ratio increases with the progression of CLD. MMP1 and TIMP ratio is also used as indicator of fibrosis. Then again, another markers like transforming growth factor beta 1 is also used. There are many markers, but HA, hyaluronic acid, procholinergen type 3 and type 4 cholinergen are the best markers so far. And for if we talk about hepatocellular carcinoma, the American Association for Study of Liver Diseases is not recommending alpha-fetoprotein for in screening. It depends only on the radiological imaging, but radiological imaging only give 82% of their chance of finding the hepatocellular carcinoma is 82% when we are using imaging, but we are using AFT with imaging. The ratio increase to 92%, and the efficacy of detecting the cancer is around 92%. That's why the Asian Oncology Summit and National Comprehensive Cancer Network added AFP in the panel with the imaging. Some other biomarkers are there which are already there, available in the market, like base gamma carboxyprothrombin, which is also known as P4Ka2. The Turasar was saying about this. It is produced by hepatocytes, malignant hepatocytes, and it is vitamin. It is not affected by vitamin K dependent. It is not vitamin K dependent, so we can use that because And the the cutoff is 100 nanogram per ml on ELISA platform. So, and it is also correlated with tumor activity and size of tumor. So the another good marker is desgamma carboxy prothrombin. And some enzymes like GGT and alpha-1 fucosidase are also available now on ELISA platform. But alpha-1 fucosidase is also increased in hepatocellular carcinoma with, and also in the cirrhosis and chronic hepatitis. So it is not that much promising, but some genetic and nuclear biomarker like AFP mRNA. AFP mRNA is best for malignant and recurrence. If a single hepatocellular carcinoma cell is present in the blood, we can find it through RT-PCR, and it is the promising marker. Then GGT mRNA is also available, especially the GGT type 2 mRNA. Then insulin-like growth factor 2 mRNA is also, the cutoff value for that is around 4 nanogram per gram, and this insulin-like growth factor is best for small hepatocellular carcinoma, to identify small size hepatocellular carcinoma. And when IGF-2 is combined with AFP, the sensitivity and specificity is increased up to 80 or 90%. Some microRNA also are used, but they are not, they are in the research and development mode. Then tumor-specific growth factor, the cutoff value is of 62 unit per ml. In AFP, there is, Sir was discussing the 3 isoform is there. The AFP L3 isoform is very much promising and now used, and even AFP L3 and AFP total ratio is also used to detect this marker. So there are many other markers, but they are in research and development. These markers are almost available on immunoassay platform, more or less, and we can use it, but they are not the definitive marker, and they are just alternative of biopsy and radiology. So we can help the patient, but they are not replacing the radiology and biopsy. Thank you, sir.
For all of you who have heard what Dr. Jamil has said right now, I think that's the most concise form of recent advances in liver biochemistry. Probably he's listed out everything which is bubbling under. Honestly, Jamil, and as I talk to you, and I'm sure most of the people in this audience might not have heard even 80% of what you have said. It's been brand new to me. Okay, I knew there were markers, but I didn't know that there were so many extensive markers. So could I request you to kindly summarize just the names of the markers and share it up in the group? Because here lies the most important thing, is that for PG students, this is a good topic for you to do your thesis on. For those who are actively researching, these are the areas where we actually start combining and handshaking clinical, imaging, and biochemical parameters, and kind of understand whether these markers are good enough to augment, supplement, investigate the modalities to understand what is exactly happening in the liver. Shuchi ma'am, do you have anything more to add on the liver function test? Dr. Jamil has covered extensively on the fibrosis part of it, but is liver function test going in more directions, or we just stuck with that?
Yeah, specifically regarding drug-induced that DILI, drug-induced liver injury, there is an anti-cytochrome P450 marker which has come up recently, and this is a very good marker to actually place whether the liver injury is progressing. It's for acute liver injury. It's a very good marker for that. Apart from obviously keratin 18, which we all know has 2 fractions, and it is also used as a marker in NASH and NAFLD. But since this keratin 18, K18 has 2 fractions, and and this is basically an apoptic stage. So M30 and M65, as has been research has been going on. So I had an opportunity to go through a meta-analysis in this, in which I studied about M30 and M65. M65 is a better marker for NASH. So NAFLD, and M30, because it's an apoptotic protein, so this is a better marker for NASH. So these two can differentiate between progression of the patient from NAFLD to NASH, a very good marker for that. Then there are many numerous markers for DILI and for NASH and NAFLD, but nowadays one more important modality has come into play, that is our genetic level testing in serology. That is microRNAs, especially 122 has been used for to study various injuries to the liver. This has a new development in biochemistry, as you can say, or serology testing. And then oxidative stress markers are there. We all know they are all just coming up, apart from NAFLD markers for this adiponectins and leptins, which have been established and are being used. But specifically, I would like to comment on this keratin 18, M30 and M65, very good markers for NASH and NAFLD. Then I was going through other diseases, among this the lysosomal storage disease, Gaucher's disease, and I got a really good quote about it, that it's a model for new biomarker study. This disease is a model, and I was really keen on going through this. So I came across 2 markers for it. One is for the diagnostic and another is one for the monitoring. 2 new markers have come up. The one is chetotriosidase, and this is for the diagnosis, and lysosomal glucosyl sphingosine 1. This is for monitoring of the treatment of patients. So Gaucher's disease really has come up with new markers. Then for hemochromatosis is very common in transfusion patients. There is iron acts as a toxic element. So we have a label plasma iron, that is non-transferrin bound iron, which is used as a parameter for hemochromatosis, and it's a very good indicator whether injury is possible with the levels. If they're high, it is producing oxidative stress, and the patients are really prone for liver injury. So that is also a promising marker. And then another marker we have is transferrin saturation T-stat. That is another marker which has come up. So what I understand with this discussion is that we can definitely, no modality can be replaced. We can augment each other for the benefit of the patient. If you start from biochemistry, then pathology, then radio imaging, all these will augment in the ultimately the aim of the medical fraternity is to treat the patient. So they all each other actually synergize with each other, and they help in the patient treatment. This is what I have understood.
You have just summarized what I was planning my punch dialogue at the end of the presentation. Okay, Neena ma'am, from the discussion so far, we've traveled a whole journey between what we are normally doing, where the normal standard liver function tests stop and where the imaging modalities take over. And then we've also discussed about the places where the both these diagnostic modalities don't help, and then we resort to either cytology or a biopsy, and they've got their specific indications where they're very important and they provide good insights into clinical management. Dr. Jamil and Shuchi madam have covered a whole plethora of molecules which are evolving, bubbling under, which could augment, supplement. With all these, in your clinical practice, do you find lacunae that, it is not singing the way or helping you to make your clinical diagnosis or management of the patient? Somewhere where you feel a bit incapacitated and probably it is falling in a blind spot, because the inputs will be important for take-home message as to where we need to go forward.
Yes, sir. Well, if we think of ideal scenario and regarding all these research molecules, which Dr. Shuchi and Dr. Jamil has elaborately told us. So main thing is which of them are actually available in the market, then whether they are cost effective or not, and whether they correlate well with the disease progression, or even they indicate that regression of the disease is being obtained by treatment of the patients. As Shuchi has said very nicely, that yes, the thing is useful as a alone test, either a LFT or a elastography or a MRE or biomarkers of the fibrosis or of steatosis, etc. They all can supplement each other, and they are actually needed by the clinicians to further assess the patient and to assess that whether they need the specialist reference and future liver transplant, etc. So early referral and early diagnosis of the patient. Early diagnosis these will help, then early referral can be there, and stage renal disease can be prevented in the patients.
So when I
thank you so much for making me part of this ACC LMP lecture team, and thanks Dr. Arun Harith. Thanks a lot.
When I started off with this panel discussion, to be very honest with you, I said, okay, let's look back and reflect. And in the last 40 years, probably we had not added anything new in the field of liver function. This was my perception, that we hadn't added anything new in the field of liver function test, and our radiological colleagues had taken a step ahead. So it was kind of I was planning to conduct it in such a way that's a wake-up call for all the biochemistry fraternity that we need to do something about it. But in the last 2 to 3 days, when I've been interacting with all the people from the different modalities and discussing with them, I'm trying to realize that we kind of working in silos. We're just working in our area and say we are doing this thing, but the crossing over the border and talking to them, what are you doing? How is this working? We're not doing that. So it was very educative enough to know a lot of information when I was discussing with Shikha, when I was discussing with Kinra, when I was discussing with Neera ma'am, as to there is a different aspect and connotation of the liver function test. Dr. Jamil and Dr. Sujit ma'am have been quite good in infusing the sense of confidence that we've not been sleeping. There's been a lot of work being done, but that's being bubbling under, done under. Typical Indian mentality, we want it to be published from the Western forum, and then we will follow it. Now, we are a whole bunch of teachers, we are a whole bunch of researchers. There is a mandate that we should be publishing a lot of articles and all that. So and we have abundant amount of cases. So the request is a collaborative effort, pick up certain molecules, evaluate it. We have the ocean of information and we could be the world leaders. We should start thinking as leaders rather than followers. It's a paradigm change that should be done. Other important thing, I had a beautiful summary line which Shuchit madam just tore it away from me, but I'll still say that the point is the patient, we should start looking at it. The patient is essential. We should be able to give a good diagnosis to the patient with as less as trauma to cause to the patient as we would like somebody to do to us. It's not the concept that you are grabbing something from me or I am grabbing something from you. We need to understand what each others are doing. We need to identify the lacunae and we need to either augment, supplement, so that collaboratively as diagnostics, we provide the vital information required for clinicians to treat the patient. And another important thing is get up from the comfort zone of the lab, walk up to clinicians to find out what bugs them. The same request is back to the clinicians, get up from your comfort zone of the ward, walk up to the lab and tell us that this is some specific areas which is bugging. Do you have a solution? And there are so many times we've come across situations where we could have provided alternates. Like a classical example of some fluid draining from the mouth. They were not sure what the stuff is. They wanted to know whether it is a drain fluid or whether it's saliva. We just said centrifuge the sample, check up amylase, check up the serum amylase, check up the fluid amylase. If the fluid amylase is very high, that is saliva. If it is matching with the serum level, that is a serosaginous discharge from the wound. Simple thing could be done, just a little bit walk and interaction. So the bottom line is that we need to A, stop working from silos, B, stop looking at each other as competitors, C, look at ways where we can augment, supplement each other, D, identify lacunae which exist in the system and collaboratively find out a solution. The bottom line, which I always say, I mean, this is the standard line I say in most of the things. Why are we looking for the ADA recommendation of diabetes when we are the diabetic capital? When we have the maximum alcoholic problem and the maximum number of people whose jisko Hindi mein kehte na liver chipa hua hai daru ke karan, when we are sitting in that, we're still looking for some foreigner to tell us that this is a better marker. It's about time we stop rethinking that idea. I really thank all the participants, A, for educating me, and B, having deliberated upon this topic in a great details. And any closing statements from the panelists? Kinra, would you like to add something?
It's a very well conducted panel discussion. That would be my one take. And I guess you have covered it very well, and you've taught us a lesson how we can work as a cohesive team. Thank you, sir.
Shikha, any additions, subtractions?
I think you've summed it so beautifully, and the speaker before you, that nothing needs to be, added more. And it was a pleasure being part of this panel discussion.
Dr. Tura, sir, you are the senior most person. Your valuable opinion, sir.
Arun sir, you have very well organized and covered every aspects of the topics, and I don't think now anything required to be added. Thank you for finding me, and I feel proud to be a part of this panelist panel.
It's a pleasure. It's a pleasure. Thank you very much, and thanks a lot for the Rajasthan chapter for organizing such a wonderful thing and covering so much things in details. Personally, I gained a lot more than whether others gained or not. I gained a hell of a lot. Thank you very much.
Thank you so much.
Thank you.
Thank
you. Thank you so much, sir, for the brainstorming session. It was really, really wonderful to listen to the seniors speaking so much and sharing the knowledgeable point of view. And I just wanted to take some questions if time permits. There are only a few. Somebody has asked about the, I think, directed to Dr. Jameel only, that what are the practical, say, the lab tests which are running nowadays to, to find out the fibrosis. I'm not finding that question, but I think Dr. Jameel has already answered. But currently practically use lab tests to detect early liver fibrosis. That is the particular question which has been asked.
To me, I already answered, but I will repeat. The enhanced liver fibrosis test is used, and European liver fibrosis study compared this with the liver biopsy, and they come with 90% of sensitivity and specificity, and they recommended that combination of hyaluronic acid, T3NT and TIMP1.
Okay, the combination of all the three.
Yeah, the combination of three. One cannot rule out this.
This will be definitely added on to the radiological imaging to kind of correlate the two, right?
Right.
Okay, sir. Somebody from the audience had asked the role of vitamin B6 supplementation on transaminase levels. So how the vitamin B6 supplementation affects the levels of transaminases?
Okay, let me ask a question to all the people, and a show of hands or yes would also be a very good way. I've had some jokers of medical reps coming to my lab and telling me that that paradoxal biphosphate is nowadays not recommended in the fluid for testing the transaminases. How many of us are aware that there has been such a change? I am not aware, so I am the first guy to raise my hand. Are there anybody who have known this? Okay, that's it. So that's a very good insight, that please do not be taken for a good ride by the rocket sings who come to sell any and everything to you in your OPD. Good. So has that been answered?
Surely, sir. One more question. What is the total bilirubin level in Indian population?
It remains the same because bilirubin level is basically dependent on senescence of RBCs. So it remains the same in Indian population, doesn't differ.
Okay, ma'am. Thank you so much. I think these were the main questions to be discussed. And
can I just add a small interjection to all the biochemists in this group? How many of you have been able to maintain a good CV percentage of conjugate bilirubin at level 1?
Very difficult.
Very difficult. That's very good. Like we have a control for level 1 conjugate bilirubin as 0.3, 0.2, which bloody does not mean anything in clinical management. But when you have a slight variation of 0.3 to 0.4 and 0.2, your CVs shoot out to 30%. And that's when the great auditors come and say, what corrective actions you have done? This parameter is under surveillance. So does everybody have this problem? Show of hands.
Yes, I had.
So is it an okay idea to say that level 1 of conjugated or unconjugated bilirubin, level 1 at 0.3 doesn't make sense? So we do not run this control, because by level 2 control CV percentages are 2 and 3%. Level 1 goes to 25 to 30% at times. And then those unfortunate questions, and the moment you show the CV percent with 120 and the guy starts digging more and he's out to pick up more problems. So are we all in sync with the idea that level 1 conjugate bilirubin means nothing?
There is, because conjugated bilirubin as such does not have any level in the blood. It may be 0 also.
Yes,
so
you do. Dry chemistry, it's always 0. Dry chemistry is always 0.
So the thing is it is a possibility that we will not have a very good CV for it, because 0 level is very difficult in QC samples.
Then a request to auditors to sync in the same frequency when they come to audit my lab.
Correct.
academic में बात करो तो सब मानता है, लेकिन ऑडिट में आकर चेक करते हैं तो 30% में गोला मार के चला.
They see, bilirubin has always been a challenge in QC. It is always a challenge.
So my general appeal to all the biochemists, stop being autoimmune. When you know that this is a problem and when you know that you can't maintain it, don't be autoimmune to come and question me. The whole audit, the only department which gets hammered is the biochemistry department. Right. Thank you very much, guys. Thanks a lot for participation.
Thank you. Thank you. Good night.
Okay,
so thank you so much for this valuable session on behalf of ACCLMP Rajasthan chapter. I literally am very grateful to have such a wonderful session and to have such wonderful participation by our seniors in the taken so much of pain. They've like worked so hard to make it happen, and I'm really, really very overwhelmed. No words to say. And I'm really thankful to Central ACC LMP and Dr. Shuchi sir for giving us the opportunity to frame a chapter of our own and giving us this platform so that we can come and we can like share our point of views, our problems and everything. And we are definitely going to be academically very much like we'll be gaining so much academically also from this platform. Although I think during this session, a lot of technical issues also occurred, but apart from that, I think we have successfully like completed this session, and I'm really grateful to all the speakers and the panelists and our moderators, sir. I'm really very much thankful. I just can't have like words to say, because we were not expecting this kind of an elaborated session to happen, and this has eventually happened. So, and I'm also thankful for all the participants who have come all the way from all over India to join us. They also took time and spared time from their busy schedule to give us the time to show and to discuss such wonderful things with us. Thank you so much, sir.
Great.
Thank you.
Thank you.
Thank you. Thank you for everyone. Thank you.
Thank you.